I'm one of the orthopaedic registrars. Today I'm going to be presenting on heterotopic ossification following hip arthroplasty. So heterotopic ossification is the abnormal formation of mature lamellar bone in extraskeletal soft tissue where bone does not usually exist. It was first described in 1883 by Dr. Vidal, a German physician. It's quite common, happens in about 10 to 40% of patients, and the majority of these patients have low-grade HO, which is not clinically relevant. However, in those who go on to develop higher-grade HO, this can be an issue because it causes reduced healing, limits range of movement, and it reduces the patient's clinical outcome. Pathophysiology exactly is not completely understood, but it appears to be related to a combination of systemic and local factors. Our current understanding is that fibroblastic cells are activated within muscle, ligaments, fascia, or skin, and then these function as osteoprogenitor cells. We also understand that inflammation may play a role in development and progression of this bone formation. And in hip arthroplasty, there is trauma related to joint dislocation and bony preparation, and that this is ultimately what may lead to eventual development of HO. HO is classified using the Brooker classification system. It's one of the oldest and most widely used systems for grading heterotopic ossification. Number 1 it refers to islands of bone within soft tissue. Grade 2 refers to bone spurs originating from the pelvis or proximal end of femur with at least a 1 centimetre gap between opposing bone surfaces. 3 refers to spurs originating from the pelvis or proximal femur, reducing the space to less than 1 centimetre, and 4 is referring to complete hip joint ankylosis due to the bony spurs. 3 and 4 are usually considered clinically relevant. This is an X-ray showing heterotopic ossification. You can see that it's visible usually between 4 to 6 weeks after surgery and can form anywhere up to 3 years post-op. Heterotopic ossification after this time frame is unlikely to be due to the arthroplasty, and then other causes of HO such as implant loosening or periarticular infection or new trauma need to be considered. There are several patient factors and preoperative diagnoses which have been found to be associated with a higher risk of this complication, and it's important to note that the literature is conflicting and limited, and that for now correlation may not necessarily mean causation, as there are a large number of confounding variables in the literature. In terms of the less contentious risk factors, these include neurological injury, being male sex, ankylosing spondylitis, having a history of Paget's, post-traumatic arthritis, a history of previous HO, hip joint ankylosis, being elderly, and having African ethnicity. And those risk factors which are more contentious and more debated in the literature include having a high BMI and having a type O blood. In terms of surgery specific, one risk factor which is most reliably reproduced in literature is having a cemented prosthesis compared to an uncemented prosthesis. Maloney et al. Published an article in the JBJ Asset in 1990 which demonstrated that 74% of patients who underwent hybrid total hip replacements developed HO compared to 40% in the uncemented group. The other less contentious risk factors include soft tissue dissection, bony debris, hematoma, and there was also some literature about approach, whether or not it had any effect, and I think the jury is still out. The more contentious risk factors include having revision surgery, bony grafting, and whether or not a patient underwent a trochanteric osteotomy. It's generally accepted that prevalence and severity of heterotopic ossification can be reduced with perioperative prophylaxis, and this largely falls into 2 camps, pharmacological as well as radiation therapy. In terms of pharmacological, the mainstay of treatment or prophylaxis is NSAIDs. NSAIDs work by inhibiting the production of prostaglandins, particularly prostaglandin E2, and that reduces inflammation, which later can go on to spur on HO production. This was a paper published, a Cochrane review in 2007, which looked at the effectiveness of NSAIDs in reducing HO production. A total of 16 RCTs were included, totaling nearly 5,000 patients. And the findings were that perioperative NSAIDs reduced the incidence of HO by between 1/2 and 2/3. However, there was a lack of data concerning any long-term benefits, such as pain control and mobility, and some patients receiving NSAIDs did also experience GI upset. The high-paid study found a significant decrease in the risk of developing HO of any grade and of developing BRCA 3 and 4 in those receiving ibuprofen. However, this did not translate into any meaningful change in clinical outcome, as there was no difference in pain in the hip or physical function between the two. And furthermore, there was an increased risk of developing major bleeding complications in the ibuprofen group. Another systemic review and meta-analysis, which was published more recently in 2018 by Joyce and colleagues, also found a significantly reduced incidence of HO in patients treated with NSAIDs compared with placebo, but this one found no difference between the use of selective and non-selective NSAIDs. Going back to medical school for a quick moment, selective versus non-selective NSAIDs. Non-selective are your aspirin, naproxen, ibuprofen, meloxicams, and your selective for COX-2 include indomethacin, meloxicam not on there, sorry, that was an error, and diclofenac. In line with recent JOS recommendations, NSAIDs should be started within the first 48 hours following surgery and no later than 5 days post-operatively to be effective. This is the treatment dose according to JOS guidelines, and that's 25 milligrams TDS for 5 to 6 weeks. It's good because it's simple, straightforward, and it's also very cost effective. Something to note though is that ibuprofen and aspirin tend to be medications that patients are on regularly anyway, perioperatively, and therefore if they're already on something, it may just be worthwhile getting them to continue on with their regular NSAID rather than switching them over to an indomethacin, given the papers before which show no real difference between the two outcomes. There are downsides to NSAIDs though, so with indomethacin it's been shown to increase the rate of non-union in fractures of long bones, and this may be of concern when an operation is performed through a trochanteric osteotomy or when uncemented components are used, as both of these techniques rely on bony union for success. There's been documented evidence of GI upset, which is worse in the non-selective compared with selective. There's also reduced compliance in these patients, and it has been shown to slightly increase intraoperative blood loss. The other factor to consider is that in patients who are already on a diuretic as well as an ACE inhibitor, introducing an NSAID can tip them into developing an AKI. In terms of radiation therapy, Milakovic et al. In a large multi-center study showed that there was no differences between radiation prescribed before surgery and after surgery, and that one dose of 700 to 800 centigrade was sufficient. This option would be preferable to NSAID therapy alone in patients who are deemed high risk. Unlike certain other combinations we have in orthopedics, there was no sufficiently powered study published that I could find to support combination therapy over single therapy. Looking at emerging therapies, while one recent animal study reported a reduction in post-traumatic HO development in mice treated with rapamycin, which is an antifungal agent, and a potent immunosuppressant normally used in transplant patients. However, human studies are yet to be performed to verify these results. Treatment is usually surgery, but surgical management is very rare. The indications for surgical debridement include symptomatic grade 3 and 4, loss of range of movement, severe limp or deformity. In terms of timing, when to do it, usually you need to wait until the heterotopic ossification is fully matured, and that would usually be between 6 to 12 months after onset. There's a high associated rate of complications in the hip, including sciatic nerve injury, osteonecrosis, draining wounds, and of course recurrence. And therefore it's important to consider performing a CT of the hip prior to removal. So, should NSAID prophylaxis be standard for our postoperative patients? I think there's pros and cons. So pros would be that it's shown to be effective in reducing the risk. There's minimal risk of harm. It also has additional analgesic effects. It's low cost and many patients are already on one. But the cons is that our elderly population particularly usually have poor baseline kidney function, and this can tip them into having an AKI. There's an associated risk of GI upset and poor compliance, and there's likely also a very high number needed to treat. So my take-home messages are that HO is common. It's a common finding after total hip replacement, but the majority are not clinically relevant. NSAIDs and perioperative radiation are safe and effective prophylaxis management therapies with a lot of literature published about them, and that surgical excision should really only be considered in select cases after 6 to 12 months post-onset. These are my references. Thank you.